let's start the webinar. Again, for the persons that just joined this room, I want to welcome each of you for this webinar on MHPSS coordination in humanitarian response. For today's webinar, we have Dr. Fahmy Hanna, which I think many people are already familiar with him because he has participated in previous webinars with us. Fahmy he has more than 10 years of experience with MHPSS.net, and we're going to start with his presentation. Just a few explanations of how this works. Each presenter will have around 10 to 15 minutes of presentation, and then at the end of the presentation, we will have a space for questions and answers. But when you have questions, you can write those questions on the left side at the chat box, and our team is going to collect those questions, and at the end, we will post those questions to the presenters. So I'm really happy and excited to introduce Fahmy, that's going to start the presentation. Fahmy, can you connect your sound and webcam? Let me unmute you. Fahmy, can you hear us? We cannot hear you.
Okay, I hope you can hear me now.
Okay.
Perfect.
Yes, now we can hear you.
Okay, thank you.
So just to introduce quickly Fahmy, he has more than 10 years experience in this field and has worked in several places, but in two places that are quite remarkable experience for Fahmy and contributions from him. It's from Syria, when he worked as a technical officer for this crisis, and also in Libya, when we met and we worked together, and he was living there between 2011 to 2014. Since 2014, Fahmy, he moved to WHO headquarters in Geneva. Since July last year, 2017, Dr. Fahmy, he is representing WHO as the co-chair of Interagency Standing Committee for Mental Health and Psychosocial Support in Emergencies, which makes his contribution here today quite fundamental. Thank you, Fahmy, very much for joining us again and sharing your experience and view on MHPSS and coordination.
Thanks, Marcio, and hi everyone. Great pleasure to join you today in another presentation at MHPSS.net. So bringing context to the topic of coordination. At the core essence of mental health and psychosocial support in emergencies work is reducing suffering for people affected by mental health and psychosocial conditions. And to do so, actors require to be involved with large numbers of stakeholders from different sectors. And that's what makes sometimes the issue of coordination challenging, because of the diversity of stakeholder involved. The term mental health and psychosocial itself is a composite term that reflects agencies which are sometimes focusing either on mental health, on prevention and treatment of mental health condition, as well as psychosocial support, which is about protection and promotion of psychosocial well-being. And the term itself has facilitated to a great extent coordination by bringing actors across the spectrum of interventions together. Coordination of MHPSS can be challenging, but it's fair to say that without the Interagency Standing Committee guidelines on mental health and psychosocial support in emergencies, without these guidelines, coordination would have been an impossible task. And this guidelines has helped the field to become more coordinated, to identify useful practices in the field, to flag harmful practices, and to clarify how different approaches to mental health and psychosocial support are complementing each other. The IASC Guidelines is providing us with guidance on what to do regarding coordination during the preparedness phase for any emergency. During preparedness, this is the time that coordinators would look around for different key players, for different actors, not only at their sites, but at different regions for focal points that can act on mental health and psychosocial support. This is a time where coordinators and actors would look into mechanisms to use. What would be the responsibility of different team members? This is the time also to think about advocacy, to start fundraising for budget, including for coordination budgets. Unfortunately, big component of this happen after emergency, but lots of time and lots of resources can be saved if this is implemented in the preparedness phase. And I remember in our previous webinar we discussed a lot about preparedness in our previous webinar about the DRR and MHPSS. Again, the IASC Guidelines is telling us as part of the minimum response, we need to establish a coordination which is intersectoral for mental health and psychosocial support. As many of you know, I'm sure many of you are familiar with the IASC MHPSS Guidelines. The guideline is telling us that we should establish one group for both mental health and psychosocial support agencies. Having separate groups for mental health and psychosocial makes the response fragmented. The IASC Guidelines also recommend that the partners participate in coordination meetings, share updates with each other, so that they can complement each other's work and they do not work in isolation. The IASC Guidelines also tell us that as part of a comprehensive response, we need to think about sustainability of the coordination of the response. We need to integrate the coordination mechanism into existing coordination and implementation structures either within the government or within the civil society stakeholders. We need to develop and also mainstream strategic plans for MHPSS within existing policies and programs, and to continue the information sharing and to link the MHPSS emergency activities into development activities that would lead to building back better, sustainable mental health care and psychosocial systems after the emergency. Part of our day-to-day work as co-chairs of the IASC reference group, we receive questions from the field. We currently have about 21 active MHPSS coordination groups globally that myself and my fellow co-chair Sarah Harrison from IFRC are providing support to. And day to day, as part of the IASC reference group co-chairs help desk function, we receive questions reflecting some of the challenges. That's what I tried here to summarize in my presentation. So I'm sharing with you 5 common challenges that Sarah and I commonly get asked on, and I look forward to hear from you more questions and more challenges that you are facing. So let me share with you one common question we receive from coordination groups and emergencies. Who should chair the MHPSS coordination group? Big question. Sometimes we see delay in starting the coordination and starting implementation of programs because groups spend lots of time thinking who should chair the group. Let me share with you one suggested model which reflects what's in there in the IASC MHPSS guidelines. As you just heard, the guidelines usually recommend having one group instead of different groups for mental health and psychosocial. The group should be a cross-sectoral technical working group with representatives from different sectors. Ideally, practically speaking, usually our recommendation is to have at least 2 co-chairs instead of 1. 2 co-chairs reflecting or representing 2 different sectors. For example, at global level, I'm hosted by the World Health Organization, which is a health agency, and my colleague Sarah Harrison is hosted by IFRC, and to a certain extent that represents the psychosocial field and protection sector. In different situations, there were different arrangements, and for different groups in different emergencies, different sectors can be represented. So ideally, health sector, protection sector with child protection subsector represented, but also in other emergencies, like in situation of extreme food shortage, one of the co-chairs can be coming from education sector, be coming from nutrition sector, depending on the emergency and depending on the context, and also the available full-time equivalent for staff, because coordination in the field can be sometimes time-consuming. So agencies nominating a focal point to co-chair a group should be also willing to fundraise or contribute to some of their human resource present in the field to contribute to coordination tasks, because sometimes this is time-consuming. But ideally, we recommend more than 1 co-chair representing two different sectors. And technical working groups are usually not sectors, not clusters by themselves. They are cross-sectoral. And accountability for different functions would remain through different respective sectors, whether health, protection, education. Ideally, also the co-chair function should be a rotatory function. Still in the coming rotation or rotations for different co-chairs of the group, the same representation, different representations should be happening either from health, protection, education, nutrition, or WASH or others. But it should be a rotatory. Again, in different appeal chapter would remain within sectors. Another common challenge we sometimes get receives this question: what terms of reference, what functions should MHPSS coordination groups have? Let's talk first about the process of developing terms of reference for MHPSS coordination groups. When we receive this question, we usually recommend to MHPSS coordination groups to review existing similar terms of reference for other groups. As I said, there are around 21 active MHPSS coordination groups in different emergencies globally. Many of their terms of reference are actually available on MHPSS.net. You can get to a specific emergency, and you can get into the emergency group, and in many situations you will find uploaded within the resource section terms of reference of different groups. If you cannot find it in MHPSS.net and you contact also the host, another also mechanism of getting it, and also you will recommend this, that you get back to the IASC MHPSS reference group co-chair, because part of our responsibility day to day is to respond to this request and help in coordination and help you as MHPSS coordination in shaping your TOR. So look into similar TOR, contact the IASC MHPSS reference group. But very important is that you discuss with your team members, with other actors in the field, when you want to formulate the TOR, and also have discussion with existing coordination structures within the country. Talk with OCHA, talk with different clusters and different sectors, whether health, protection, nutrition, education, WASH, or camp management or others. So this is about the process. TORs looks sometimes different, but in most situations, in most TORs that you will find on MHPSS.net for currently active groups, usually you will find all or most of these functions are included. Usually MHPSS coordination group are having a mapping function, looking into available resources in the field. Also, MHPSS coordination group is facilitating and supporting inter-agency joint initiative, whether this is for assessment, for planning, for resource mobilization, for capacity building. MHPSS coordination group also mainstream and disseminate IASC MHPSS guidelines and tools. One of the good practices we see in many coordination groups is that the coordination groups would assign focal points, and each focal point would be responsible for a specific cluster or specific sector, where they work within the cluster or sector and mainstream the IASC MHPSS guidelines and tools. Coordination groups also is a good venue for exchanging good practice, challenges, learned lessons, as well as knowledge generated and resources. And this definitely help in avoiding duplications in the field. Third challenges. Common question we get: which tool should the groups use? Should the coordination groups use? And the question sometimes is different, whether it's about which tool to use for mapping, for monitoring and evaluation, for referral. Good news is that many of these tools exist. The IASC reference group across the years has developed different tools. For example, if you want to do mapping, who is doing what, where, when, in mental health and psychosocial support, there is one specific tool for this, the 4Ws tool of the IASC reference group, again, available on the website of the IASC, as well as on MHPSS.net. Actually, on MHPSS.net, you can find a specific group which have different mappings, different Excel sheets for 4Ws that was used in different emergencies. Again, IASC MHPSS reference group released the common M&E framework, also available on website and MHPSS.net, and a specific referral form and guidance note. And we have workshop material for the guidance note on referral available from the reference group on request. As you know, sometimes one of the challenges of coordination we see in the field, we see it with referral between GBV and MHPSS, referral between protection and MHPSS, referral between mental health and psychosocial. So there is a specific and dedicated referral tool from the reference group for that. Should MHPSS coordination group create its own chapters of CAP, of Consolidated Appeal Process? The answer is no. And I'm quoting here the handbook for resident coordinator and humanitarian coordinator on emergency preparedness and response, which clearly says that MHPSS project should be integrated in relevant chapters of protection, health, and education. Fifth and final question: what should the group do after the emergency is over? And the recommendation is that starting from early recovery, you should start mainstreaming the group functions into existing implementation and coordination mechanism to facilitate building back better. I'm putting here an example of good practice from an emergency where coordination was definitely a challenge in Haiti earthquake in 2010, and the MHPSS coordinator at that time was collecting mapping information from 100 agencies conducting MHPSS activities. If you want to read more about this case study, it's available in this resource in the 4Ws MHPSS, available on MHPSS.net. What's next from the reference group regarding coordination? One of our activities in the current year and the coming year, in fact, work plan, is that we are looking into surge capacity. We're discussing with different agencies and different actors mechanisms that would enable us fast as a reference group to deploy coordinators when emergencies arise. So this is one area we will continue to work on in the coming 2 years. Also, another area we're looking at is building capacity of existing coordinators. So we think that sometime between 2018 and 2019 we will have training activities which will be conducted for field coordinators from different emergencies and help knowledge exchange on good existing practices among them. Thank you.
Thank you so much, Fahmy. We very much appreciate your sharing. Imagine the field, the MHPSS global field, without the guidelines. What a statement, which is true and provoke us a lot. You know, the challenge in the field for coordination. And I think even the interest of this webinar shows it. More than almost 300 people applied for these webinars and etc. So it does show how this is a difficult question, an important question. Thank you very much. And now we are going to go straight to Michael. And I just want to remind everyone that's participating here that do make your questions during the presentation. You can write on the left box, as you can see where there is this chat box. And my colleagues and I, we are going to collect these questions and put it at the end of the webinar. So sooner you make your question, better it is and easier for us to coordinate the questions. Michael, can you hear us? Hello, Michael. Can you speak here? We cannot hear you, Michael. Can you try to speak again?
Hi. Can you hear me now, Marcio?
Yes, great. We can hear you. So, just briefly to introduce Dr. Michael Copland, which we have the pleasure and the honor to have him in our webinar. Welcome, Michael. We very much appreciate your acceptance for this webinar. Michael is the Global Coordinator of the Child Protection Area of Responsibility led by UNICEF, and he has over 20 years of professional experience in managing humanitarian field operations and child protection programming, including postings as a technical specialist on child release and reintegration programs in Sri Lanka, Uganda, and South Sudan. Michael holds a degree in social work and international law from the University of Melbourne, Australia, where he has worked as a family counselor and group program clinician in adolescent and mental health services. Michael, the floor is yours. Thanks for joining us.
Thanks, Marcio, and thanks everyone for joining. Just briefly on the introduction, as Marcio is saying, I started out my career as studying social work and working in adolescent mental health programs. I then studied law, but I'm not a doctor, but I've studied across those areas. I'm grateful for the chance to be with you this afternoon, and I wanted to start out just with a few words about, from my perspective, why it matters, coordination and MHPSS from a child protection perspective. So the Child Protection AOR, as I'm sure many of you know, is part of the protection cluster, so led by UNICEF, and we're working to support country-based coordination groups globally, and I'll talk a bit more about the support that we provide. The mandate there is to provide that support, also to deploy staff to the field to work on policy and advocacy, improve service delivery, coverage and quality. So I just wanted to make a couple of points about the why. When we look at child protection globally, and if we take our big country operations in humanitarian settings, what we see is that a significant proportion of the programming profile is PSS, psychosocial support. So this means, for example, in country contexts where we may have $20, $30, $40 million worth of programming being presented on the basis of a humanitarian needs overview into a response plan, we're talking potentially about hundreds of millions of dollars. So the why, the purpose of coordination is to improve the quality and the coverage, and if so much of the child protection programming profile is PSS, it's critical that we do the best we can to make sure that the quality and coverage of those programs are in place. I think it's important to make this point because there are many challenges with coordination generally, and if we talk with child protection colleagues about those challenges, they frequently tell us coordination can be bureaucratic, it can slow things down, it can leave us in our own silo or in our own specific area, and we may end up simply replicating models globally, a one-size-fits-all approach that doesn't work for different contexts. So coordination itself, we can say, needs reform. We know that the average lifespan of emergencies is 15+ years. We still work largely on annual funding cycles, annual assessment cycles, annual planning cycles. That needs to shift. We know that many of the mental health and psychosocial issues that we see for children and their families are exacerbated by the humanitarian situation, by displacement, by economic issues, by livelihoods. So we need to work across sectors and clusters. So in general terms, there's a lot that we need to do to improve coordination. And this, I think, applies to mental health and psychosocial support. So just quickly about where we're working, and you can see on the map there the areas of focus. And what we see, importantly, is that in different contexts, we have different kinds of coordination configurations. Frequently, coordinators of child protection are doing two jobs. They're double hatting, as we would describe them. So they're responsible for running child protection programs and coordinating. That's not optimal. We're advocating, given the critical nature of coordination, that we have dedicated coordinators. That's a challenge, and we advocate in terms of resource allocation that coordination is dedicated, because if we're going to spend hundreds of millions of dollars globally, spending a very small proportion to make sure that the quality and the coverage, the lack of duplication, etc., for us that absolutely makes sense. So we see double hatting, we see UNICEF leading child protection coordination globally, we see shared coordination structures with international partners, with governments, and I'll talk about that a little more, but we see a range. We also see in those coordination groups a significant proportion of local actors, which is important for this afternoon's or today's discussion. The majority of members of coordination groups are local. The majority of services being provided are being delivered by local partners. We see that both the proportion of membership and services by local partners increasing, possibly due to the nature of conflict and crisis, issues like access. But if we're talking about how to coordinate and how to do that better in MHPSS, at least from a child protection perspective, that means how do we work better with local partners and how do we work better with governments who continue to have an accountability, responsibility to protect children and their families and to deliver services. So just really quickly, these are some of the ways that we try and support country-based coordination groups globally. So as I said, we surge and deploy staff to these contexts, which is one of the ways that we learn about what's happening at country level and provide support. We also support a remote help desk to these countries. We track and analyze requests coming in so we can understand better the nature of the request and the location for resource allocation. Okay. So as I mentioned, oftentimes child protection programming is the main source of PSS for children and their families. So in a lot of contexts, the child protection programming footprint is relatively large. It features across the range of child protection programs, for example, demobilizing children associated with armed forces and groups, family tracing and reunification, mine risk education, working with communities, case management. So across that spectrum, we see dimensions of PSS. We see a lot of connectivity with local communities. So this presents, I think, a great opportunity to improve the overall MHPSS work being done in any given country. How do we work? How do we work together with child protection better? In a lot of contexts, we may see limited mental health services in humanitarian context, and we would see relatively large-scale PSS programming being delivered by child protection actors. How do we link up? Fahmy was just talking about making referrals, but also what do we do when we do not see services? How do we advocate together as a collective based on that mapping of who's doing what where, but also the analysis where we see those gaps. So lots of potential if we're working well with child protection. So child protection actors currently are mainly working at those first, second, and third layers of the MHPSS pyramid. So this means that wherever possible, child protection is working closely with education, nutrition, trying to mainstream the work. I would argue we need to do much more. I mentioned that the livelihood, economic situation, for example, is really having an impact on children's psychological well-being, on their overall protection. How do we work better with other actors in our work? On this, in terms of coordination, I'm sure many of you are familiar with approaches around mainstreaming our work, which I think it's fair to say has really been based more around actors from particular sectors providing material for others. So checklists, for example. The challenge remains, how do we truly have integrated approaches where we have shared objectives, where we work together with other clusters and sectors throughout the cycle of assessment and design. So I would say we still have some way to go. So if we look at our current humanitarian situations, children represent a majority, and this can be very significant, going up in some cases to 3/4. The nature of current crises and the kinds of child rights violations that we see, particularly in settings of armed conflict, where we have targeting of children, killing and maiming of children, abduction, recruitment and use, sexual violations against children, attacks on children's hospitals, schools. All of these are having a significant impact, and unfortunately, over the last number of years, we've seen a deterioration and a downward trend in the nature of crises, a failure to respect international humanitarian law, having a direct impact on children and their families. So in these contexts, children are particularly at risk, along with adolescents who are children, by the way, and an important point that apart from 19-year-olds, children being under 18 include adolescents. So child protection actors have consolidated a variety of interventions and packages to meet those needs of children. However, it's important when we're thinking about coordination that we need to work with other actors, and particularly mental health actors, understanding the range of issues and support, and particularly if we look at adolescents in a lot of settings where we are faced with suicide, for example. Thinking about the coordination and trying to link with some of Fahmy's comments, it's critical that MHPSS gets visibility and voice during the interagency decision-making process. This includes when priorities around intersector assessments, rapid response missions, in-country humanitarian pool fund allocations are being identified. So for those of you who are familiar with humanitarian architecture, we go through a process every year around humanitarian needs overview, humanitarian response planning. So the extent to which mental health and psychosocial support features not just at a sector or cluster level, but across the sectors and clusters, and being helped to be put forward by those coordination groups to ensure that MHPSS is cross-cutting, is being prioritized from all of the different angles, not just protection and health, as I mentioned, across the different domains: nutrition, livelihoods, education, camp management, and so on. As much as we are challenged by the existing architecture in many instances, if MHPSS does not feature in those assessments and in those response plans that are put forward to donors, we are going to struggle in terms of resource mobilization. A critical role for the coordination groups here is being a platform for advocacy, as well as making sure that the technical capacity across those different areas contributing to MHPSS is in place. I also mentioned about advocacy on where we see actual gaps in service delivery. So not just making referrals, but also looking at where services are being provided or not being provided. In some cases, we may actually see child protection actors seeking to make referrals for more specialized services, but services are not in place. So what do we do together as a collective across the spectrum of MHPSS to advocate and build that capacity? So I just mentioned about humanitarian needs overview and HRP processes, how we can work with coordination groups to get the right input. As Fahmy said, we need to be clear that the accountability still rests with clusters and sectors, and I think this is important. Whilst we need those coordination groups which are cross-cutting across the different sectors and clusters to play a vital role, accountability for providing services, for raising and leveraging resources is not devolved, it's not subcontracted, and it remains. And this is very important because, for example, child protection has accountabilities to provide services, for example, psychosocial support services. And the creation of a group does not mean that the service delivery and the resource mobilization and that programmatic dimension has been outsourced. I think this is important because I think a number of the challenges that Fahmy mentioned are also understanding not just what the coordination groups are, but what they are not. I think this is very important. I mentioned multi-sectoral work. I think just quickly on this, it's very important that we improve the extent to which we're working across clusters and sectors to deliver multi-sectoral needs-based assessments. We still struggle with doing individual cluster or sector assessments, which do not reflect the way that individuals, families, and communities conduct their lives. So how can we have more comprehensive approaches to assessments that make more sense for families and communities, that are needs-based, that are not based on our preconceived ideas of need, for example. There's work happening in this area. It needs to be strengthened. We talked about referrals. A quick point on this, that establishing the referral pathway itself may in some cases be possible, if not easy. Keeping those updated, using those, checking the extent to which they actually make sense, I think is the challenge. So actually looking at, for example, the referrals from actors within protection, for example, between GBV and child protection, recognizing a significant proportion of survivors of sexual assault are children. How do we work with health actors? How do we work with families as well? So if we think about an area we certainly are focused on in terms of our coordination, it's about family-based care. So supporting children, supporting their caregivers, supporting others who are in direct contact with children. So practical dimensions of coordination that are required. How do we work with teachers, community health workers, for example? So I wanted to end with a few reflections. The average lifespan of a crisis or an emergency at the moment is beyond 15 years. The turnover of international staff in these settings is significant. The role of government is variable, their accountability and responsibility remains. If we think about working with local systems, to what extent in our coordination are we working with local actors? Are we working with government? It may not be the same in all contexts because of the complexity of emergencies, including where we have different parties to the conflict. But particularly for child protection, where a lot of our work has a statutory dimension, including children's care arrangements, we must find a way to work with local authorities, including government. Local agencies provide the majority of services in many settings. So the extent to which we can coordinate effectively with them is going to boost the efficiency and the quality, is going to help us build local systems in the process. So I think this is very much part of the MHPSS coordination discussion. How can we get better at this? The second point, to what extent do we train and learn together across sectors? If we are saying we are a coordinated group and we need to coordinate better, how are child protection actors working with health actors, working with education actors to learn together as a team? The final point, how do we have coordination structures which maintain and are clear on those accountabilities for which different agencies as cluster lead agencies have signed up to? I'll stop there.
Thank you so much, Michael. Thank you so much, Michael. We will move straight to the next presentation. As Ananda already explained in the chat, we have Fahmy will need to leave. He needs to take a flight. And we are very lucky to have Sarah Harrison, which is the co-chair of the reference group. And she will be present with us as well at the end. If Fahmy is not around for the questions and answers, Sarah can take the questions and answers. Thank you so much, Sarah, for coming at this moment. I just want to emphasize during this last presentation of Nour and Rabih, please make your questions, and we're going to collect them, and just after those questions, we are going to start the questions and answer sessions. Nour will basically do the presentation, and Dr. Rabih will actually participate more on the questions and answers part. And just as a very brief introduction, Nour is a public health professional and currently the policy and advocacy coordinator at the National Mental Health Program at the Ministry of Public Health in Lebanon. And she's leading the coordination of the Mental Health and Psychosocial Support Task Force, which aims at ensuring an effective, coordinated and focused interagency response to the MHPSS needs of persons living in Lebanon, with a special focus on persons affected by the Syria crisis. And she also coordinates the development process of a mental health related efforts to mainstream mental health policies in other sectors. And Dr. Rabih El Chammay is a psychiatrist and currently the head of the National Mental Health Program at the Ministry of Public Health in Lebanon. So, as you can see, we are very much eager to hear the two of you as a very concrete operational context of a coordination mechanism. Nour, we are having a lot of back noise, so I need to ask you to reduce the volume of your computer so we can hear you, but the back noise, it's making a big noise here, probably because of the interaction between the microphone and the speaker. Let me unmute you and check. Yeah, so we still have a big back noise end. So can you try, do you see a green button on the top of your screen, like a speaker? Can you press that button? the speaker. You have no. It is still there. So try again to can you write to us here the presenter box, Nour, more or less what you see on your screen, and I already explained to the public, to the participants. Rabih, I need to mute you because it's a big backend noise. And it's very loud for all the participants. There is a big echo, so you need to mute your speaker, and you won't be able to hear us, and only will be able to speak. Yes, great. Can you, yes, it sounds like it's working now. Can you speak her? Yeah.
Yes.
Alhamdulillah. All right. So apologies for that, and let's go straight.
Okay, so thank you, Marcio, and good afternoon, everyone, or good morning, depending on where you're connected from. I would like to start by thanking the MHPSS.net team for giving us the opportunity to share our experience in coordination of MHPSS in Lebanon. And we look forward to hearing your comments and questions at the end of the presentation. For our presentation, as one of the unique features of coordination in Lebanon is that it is government-led, we thought of starting with laying out the UN frameworks that have touched on this before delving into the Lebanese experience with a presentation of the context amidst the Syrian crisis, and then presenting how the coordination is taking place, and then sharing with you some lessons learned and key considerations for coordination. So starting with looking at UN frameworks and the place of governments in humanitarian coordination. If we look at the UN General Assembly resolution that provides the basic framework for humanitarian assistance, Resolution 46/182, which focuses on strengthening coordination of humanitarian assistance, we see that among its guiding principles, the resolution emphasizes that governments are responsible for initiating, leading, and coordinating humanitarian assistance. The resolution also highlights that actors in the international system must direct their contributions to supplementing and supporting national efforts. After this resolution, which was adopted in 1991, the intergovernmental legislative framework around coordination of humanitarian assistance was expanded. And in 1992, the creation of the Interagency Standing Committee was stipulated. This committee, by definition, includes executive heads of key humanitarian agencies, UN agencies, Red Cross, Red Crescent, and consortia of non-government humanitarian organizations. As such, this committee does not include governments, and it has the function of coordination, policy development, and decision-making. If we look into the interagency guidelines, which Fahmy has comprehensively presented to us, and try to see what is the role of governments highlighted in these guidelines, we notice that there is no mention of government leadership of humanitarian response. The guidelines do emphasize that MHPSS coordination groups should encourage the inclusion of representatives from key government ministries in addition to UN agencies and NGOs, but there is no mention of any potential role of governments in leadership. Two other questions come to mind when looking at these guidelines. As Fahmy has highlighted as well, the guidelines emphasize the need to develop interagency national policies and plans for MHPSS emergency response. The question that comes here is, can we qualify interagency plans as national if no government entity is directly involved in setting them and in officially endorsing them? Another key point emphasized by the guidelines is the need to link MHPSS emergency activities with development activities. However, how can this linkage between humanitarian and development be made if the role of governments is not well articulated in this endeavor? With these thoughts in mind and general considerations, we will present the case of Lebanon, which, as I said, the coordination of MHPSS is government-led. Lebanon is a small country in the Eastern Mediterranean region with a population of around 4 million persons and including 180,000 Palestinian refugees, and with a long history of political unrest and civil war. With the onset of the Syrian crisis, the resident population of Lebanon increased suddenly, reaching a peak of 30% increase in 2013. Currently, there are more than 1 million registered Syrian displaced in Lebanon, thus positioning it as the country hosting the highest number per capita of displaced persons. This has led to a high impact on key determinants of health, including economy, employment, and basic services such as social and health services. This has led to an overstraining of the health system with increased utilization and demand on health services, including mental health services. And this has widened the already existing gap in mental health care due to the weak mental health system in the country. Although UN agencies, national NGOs, and international NGOs have provided assistance for a spectrum of services, the needs of the host community and displaced populations were far from being met. A report in 2013 by UNHCR revealed the lack of MHPSS services, lack of coordination, and a weak referral system. Building on the results of this report and recognizing that crisis can be an opportunity to build back better, the Ministry of Public Health of Lebanon committed to a long-term vision for sustainable mental health reform. And the ministry took 3 major strategic steps to move towards this long-term vision. The first step was to establish and take the leadership of a national MHPSS coordination mechanism for mental health response to the Syrian crisis, the MHPSS task force. In parallel, the ministry established the National Mental Health Program with the support of WHO, UNICEF, and IMC to chair the coordination mechanism and lead the mental health system reform. And a year after its launching, the program launched the first national strategy for mental health covering the period of 2015-2020. The strategy's vision is that all people living in Lebanon will have the opportunity to enjoy the best possible mental health and well-being. As such, the strategy includes all persons, whether Lebanese or non-Lebanese, and thus includes displaced persons and refugees among those the system that is being built, the persons who the system will respond to their needs. The mission of the strategy is indeed to build a sustainable system that can ensure universal accessibility to high-quality mental health, curative and preventive services. A key feature of this strategy is that it dedicates a domain to vulnerable groups. By vulnerable groups, we mean those groups that are at a higher risk to develop psychological distress or mental disorders due to their circumstances and that need particular attention when it comes to mental health. Among 13 groups identified, the strategy includes displaced persons. And the objective to cater for the needs of these groups is to develop an annual action plan for the MHPSS coordination mechanism and monitor its activities. As such, the MHPSS response to the Syrian crisis in Lebanon is actually anchored within the national policy framework for mental health. How does the MHPSS coordination function? The task force is chaired by the Ministry of Public Health and co-chaired by WHO and UNICEF, which are the main UN agencies for health and child protection, thereby making sure that there is high chances of intersectoral coordination. The task force today includes around 60 organizations, UN agencies, local and international NGOs, and ministries. The task force meets on a monthly basis at central level in the capital and at regional level in 3 major governorates. The task force's mission is to ensure an effective, coordinated, and focused interagency response to the needs of persons living in Lebanon, with a special focus on persons affected by the Syrian crisis, in line with the National Mental Health Strategy of Lebanon. To achieve this mission, an annual action plan is developed by the task force. The development process aims to be as participatory as possible, starting with an online survey to gather feedback of implementing actors on gaps and challenges in MHPSS work and on perceived priorities that need to be addressed by the task force. These results of the survey are discussed in the task force meetings to further articulate the challenges that need to be addressed. The results are then triangulated with results of relevant assessments and service mappings available. And the priorities are then used to draft the action plan by the task force chair. And the draft is then reviewed by task force member before it is finalized. This process and setting of an annual action plan enables the setting of priorities and has facilitated many achievements of the task force in different areas of action, whether in terms of capacity building, where, for example, the capacity of child protection and SGBV staff in safely identifying and referring persons in need of care was built, or the capacity of mental health professionals on evidence-based psychotherapy approaches was built as well. In terms of coordination functions, key achievements include the facilitation of mappings of services. And the task force is currently finalizing an online 4Ws mapping platform to further ensure timely mapping of services. In terms of service development, the task force was able to contribute to achieving the goal of the National Mental Health Strategy to organize and scale up mental health services in line with the WHO pyramid of optimal mix of services. Achievements also include the development and setting of national normative documents, such as standard minimum recruitment criteria for professionals working in mental health, or MHPSS indicators to ensure that national data is being developed to inform service planning. These achievements at different levels and the coordination of the task force across time has taught us many lessons. 3 main lessons that we would like to share with you. The first one is related to the importance of having an annual action plan for the task force developed in a participatory manner and that contributes to building the national mental health system. This is very important as the action plan can ensure consensus on priorities, enhance coordination, and optimize resource utilization and allocation towards priority areas that respond to the needs and contribute to building a sustainable system in the country. The second lesson learned is the importance of setting clear terms of reference, as also emphasized by Fahmy, and clear membership criteria to increase accountability and engagement of MHPSS actors. Indeed, it's not enough to have a coordination mechanism in place that's functional if actors are not committed to actively participate in the work of this mechanism. So the governance model that's adopted for the task force must increase commitment to joint action and promote the move from coordination to collaboration in line with the national plan. The third lesson learned is the importance of developing and enforcing normative contextualized technical documents. For example, the guidelines and standards that I have mentioned, in addition to soft governance tools. For example, the Ministry of Public Health, as chair of the task force, has issued in July a circular related to projects in the field of MHPSS, asking actors to coordinate with the ministry to ensure that any new project in place in MHPSS complements and contributes into building the national mental health system and to avoid any duplication. And this is proving so far to enhance coordination and optimize resource allocation while responding to the needs in an effective manner. These lessons learned have pushed us to think about key considerations for coordination of MHPSS in emergencies that we would like to share with you. The first one is the importance of engaging actors around one action plan to increase effectiveness and responsiveness to people's needs. The second key consideration is the need to recognize that humanitarian response strategies should contribute to and be integrated in national development strategies. Why is that important? Because the absence of synergy between humanitarian and development can hinder or delay the execution of sustainable solutions. This gap between humanitarian and development can be mended by government leadership of humanitarian response. This brings us to our third consideration, that promoting ownership of governance over humanitarian response strategies is essential. Government leadership is key for ensuring effective implementation of the functions of coordination that are emphasized by the IASC Guidelines and international humanitarian frameworks for coordination, including increased efficiency and effectiveness, improved intersectoral coordination because it can facilitate intra-government synergies and cross-government coordination. The states and governments, after all, hold the greatest responsibility in responding to the needs of persons affected by humanitarian crisis within their territories, as emphasized by the UN resolution that we have mentioned at the beginning of our presentation. And they are and should be accountable for responding to people's needs. With these thoughts and considerations, I would like to end the presentation. And if you would like to have more information or consult any of the documents that are mentioned in the presentation, you can consult the National Mental Health Program's webpage on the following link, or please feel free to contact us on the following addresses. We look forward to hearing your comments now and your questions.
Thank you so much, Rabih. Very much appreciate your presentation. So now we are going to start the questions and answers session. We have collected some questions that we have already posted to all presenters. And to start the discussion, we would like to present. We start from the end of the questions with Aladi, that's connecting from Iraq, and his question. And this question could be addressed to all the presenters actually. How do you propose to address the seeming political, compartmentalized nature of MHPSS coordination within the cluster systems? Child Protection Subcluster claiming to lead the MHPSS, Protection Cluster lacking support to protect persons with mental health problems, and other aspects of it, as there is still gaps in collaborating among clusters, and where and how MHPSS may be integrated in respective cluster response plans and funding. It's what, as a person coming from the field, is what we normally see and very often in the field. It's somehow also identified as agencies, competition. So the coordination also touches some aspects of funding system, visibility system, and how, in your experience, you have seen the presence of this problem and what you see could be the contribution to overcome those challenges as well. Perhaps, Mike, you would like to start answering this question? And then we pass to Rabih and Nour. Michael, can you hear us?
I can. Can you hear me?
Yes, we can hear you.
Okay, great, and thanks for the question. I think it's incredibly relevant because it touches on a number of the topics we've talked about this afternoon. The first is clarity about MHPSS coordination groups, both what they are and what they are not. I think frequently that lack of clarity, particularly in terms of resource mobilization and agency accountability, can contribute to some of the challenges. So that would be the first thing. And as Fahmy was presenting earlier on, looking at TOR for coordination groups, making sure there is that clarity, getting support from colleagues from the reference group in developing and setting up. I think it's also about seeing the collective responsibilities. There's certainly more than enough work to do across the MHPSS spectrum. So I don't think it's a case that there's not enough space. There's more than enough space. I think we need to get better at having that broader overview on gaps analysis and how we can work together to advocate and to get those resources in place. I think this is a critical starting point. So, as I was saying earlier, not just who's doing what where, but who's not doing what where and what the gaps are, and everyone seeing that has an impact on all of our work, whether you're more focused on PSS or mental health, and how can we come together to address that as a collective. A gap in one part of the system is going to impact on the others. So I'll stop there and perhaps hand over to Nour and Rabih.
Thank you, Michael. Thank you, Michael. So as far as what we've learned from Lebanon's experience, there are two main components that might play a role at addressing the challenge of the clusters. The first one is simply communicating and having good relationships with the people in other sectors and explaining what's the aim of the coordination. Usually helps people don't understand what protection people say, and protection people say is not understood by health people. And so both think that their interlocutor don't get the essence of their work. And I think this is where it lies. It lies at the fact that there's no cluster more important than the others. There's real need for both, specifically in MHPSS. So building these relationships on the long term, talking to people regularly will definitely help. Because at the end of the day, it's not about the systems, it's about the people within the systems. And it's the people who push the system in one way or the other. And another way of looking at this is also seeing how the government role can be reinforced to avoid the vertical interventions of clusters in humanitarian settings, because usually the structures of the government in a country are multi-layered, intersectoral, and are already linked. So if these clusters can be feeding into the already existing structure, for example, in Lebanon, we work very closely with the Ministry of Education and the Ministry of Social Affairs. So we don't have this clear cut between MH and then PSS and the fragmentation that might happen. I'm not saying it's easy, but I'm saying that there are solutions if we use the government structures and if we talk to people more.
Thank you very much for your considerations on these questions. Another question, which I think also addressed the three of you, would be how the coordination mechanisms can ensure or can use engaging survivors to actively engage on their process of recovery. So which I think is talking about in a community-based approach. How the presence of the international organizations and all the international knowledge in a local context can work well with the national authorities, even if it's fragile. The local contexts and NGOs might have a very different gap between approach and knowledge and experience, and in which way we can also engage the local survivors, the community themselves, to be part of their own process of recovery. We can start from you, Michael.
Thanks, Marcio. Sorry, I missed the first part of what you were saying. You were talking about survivors, correct?
Yes. So basically, the questions, there are two questions here, and Michael, I think we have a bit of back noise from you. Basically, the two questions from some of the participants. One is the interaction between international organizations and the local coordination mechanisms, and the risks and the challenge and also the opportunities for that kind of interaction. What are the aspects that need to be considered to that this interaction is more productive and not clashing or overlapping? And also in a question that is similar in a way that how the local community, the survivors themselves, they can be part of their own recovery, in an active role, not in just receiving the aid or the support, but they are actually protagonists of their own recovery, and in which way the coordination mechanism can facilitate that kind of process. Is that clear for you now, Michael?
Hello. Okay. Hello. So I'll take a try and then go to Nour and Rabih. So a few comments. The first, I think, in terms of working with local communities, working with survivors, working with affected populations, I think the starting point is who is telling the story. because frequently when we conduct assessments and needs overview to generate that story that then is used to to get an overview, design our response plan, and to move the humanitarian machinery forward. Telling that story is really done externally to a large extent. So I think the tools that we're using in terms of assessments, the way in which we work with local partners to participate in a meaningful way in those assessments is critical to all of this, because that forms the foundation of what we're doing. So I think that's the first thing. I think it's not a simple answer to say if we have local partners involved, therefore local communities will get better involvement, because of course local partners themselves, may to varying degrees be reflected in different parts of the power structure themselves. So I don't think it's a simple answer, but I think it does hold some of the answers. I think. Sorry, there's feedback. I think in terms of working with local systems in complex environments, including government, I think it's important to realize that we have counterparts at the technical level within ministries who, even if the country itself is in the middle of a crisis, they frequently held those positions before. They're civil servants. And we're able to connect and work with them. So I think we also need to be more sophisticated when we're talking about working with government, because we must find a way, not just because of the issues that Nour was mentioning around responsibility and accountability, but also because of the nature of the services that we're providing. So I think looking at which part of government as well. I also just wanted to make a comment about how do we get past the separations or the fragmentation of our work. And on Rabih's point that it's about understanding and language, I think frequently as I mentioned earlier, we're just passing each other across sectors and clusters, our checklists and our mainstreaming material, and the language that we use may not be shared. I think one of the answers is actually having people to learn together and to train together to look at some of those assumptions, to check if we're actually understanding and working with each other. A final point to jump back to the one on survivors. I think we need to be very, very clear that in terms of working with survivors, there are clear protocols about not doing harm as well. And unfortunately, we do see still in humanitarian settings, humanitarians working directly with survivors in ways that are not safe, which are not based around consent, which are doing harm, including how we engage with the media. So just to say, I think in terms of how we consider that, it's important to come back to those protocols. Understanding, of course, agencies are wishing to advocate and in some cases leverage resources, but I think we need to be just really clear and careful, and we can share some of those protocols afterwards if they're helpful. Stop there.
Sorry. Thank you, Michael. Well, to add to what has been said, when it comes to INGO, actually they're around the table with the local NGOs, and when the action plan is developed, they might select specific objectives that they would like to work on, and then we develop protocols or proposals together, and then we submit. So we use their technical expertise, their good relationships with funders to support also local NGOs. So INGOs and local NGO and the ministry are working together in a quite synergetic manner. because the ministry does not receive any money directly. So the money for specific objectives is written in a proposal with an international NGO, and sometimes some of the implementers are the local NGOs as well. When it comes to the participations of displaced populations and communities themselves, there are different layers. The first layer concerns the technical people, the MHPSS technical people who are part of the displaced community. And we had in the task force a few psychologists from Syrian origins who were coming to a few meetings, then they stopped because they either left the country or they're continuing their studies. On a level of getting the action plan in line with the needs of the community, we have a needs assessment that we try to do every here and then to make sure that whatever we're doing is in line. Because the problem is not to take the easy road and to have two persons representing only themselves just because they were displaced and say that we have a representation of the displaced community. So token participation actually is not real participation of displaced population. And this is something that we would not encourage. If you want to participate fully in the process, there should be mechanisms in place. Last, when it comes to research, we had in Lebanon a few risks where some international companies, NGOs came and started experimenting with no protection or research framework. And this has led the ministry to object formally to the UN in a big UN conference to stop a side event, and then to issue a circular that you could also find on the website of the ministry saying any research related to MHPSS for displaced population, in addition to the IRB that it might have from abroad, it needs a local IRB plus 3 conditions. 1, a very solid safety planning for persons who might be at risk of harm for themselves. 2, ensuring access to services and not only giving referral capacity, you can go here and there, but ensuring the service as part of the research if need be. And 3rd, having a clinician part of the research team if the research in any way tackles anything clinical. And this circular was communicated to the INGOs, academia, and donors. So participation is very important, but also it's very important to do it in the proper manner.
Thanks a lot, Rabih and Michael. I just want to remind the participants before they leave that we have an exit survey, and for the ones that participate in the webinars often already know that this is quite, we insist on these questions because though the questions might, we might repeat the questions, they are quite informative for us to feedback the webinar series that we create. So please go ahead and answer the questionnaire with the link that Ananda just posted there. We are coming to an end of the webinar. We are going to go to a last round of questions and answer. I will put the 2 questions together, and then I will pass first to Michael and then to Rabih El Chammay. And please do also your final considerations on your presentation. And the 2 final questions, they are not that easy. They are quite also provocative. The first question is the relation about funding system in the humanitarian context, donors' approach, and MHPSS programming and coordination. In your view, it's an open question. No? What are how the influence of donors and funding current systems in place influence the MHPSS coordination? Either to facilitate, make it easier and to support, and also to create some level of structural conflict and competition. And Yes, and what has been your view, your experiences, or that are matters of advocacy that should be considered in this aspect or not? So we would like to hear you from this perspective. And also, another question is related to a regional approach for coordination mechanisms. So which is not a focus approach only, but a regional approach on MHPSS coordination. How you see what has been in your experience for regional coordination. Thank you. Michael, it's your floor.
We can't hear you, Michael.
Michael, can you hear us?
How's that?
It's a bit of back in the noise. Okay.
So, yeah, quickly. Firstly, on donor engagement, by their own formal policy that they've signed on to as donors and abiding by good donor policy, there is an interest at a formal level in promoting efficiency. So I think a concern that donor funding may be leading to fragmentation or cooperation or competition. I think the point is that a coordinated response, or if this should be highlighted by the collective to say, listen, you are funding different actors in different ways, and we would like to propose something different. This is why we have all of these different mechanisms with donors. So I think that's important, and I think it's an example of why we need coordination groups to speak with one voice about what's working and what's not. So that's the first one. There are many donors. Some are more interested in getting directly involved in technical discussions, technical issues. Others not. Country-based coordination groups make decisions carefully about the benefits of having donors in that discussion. Typically, they may do so if the donors being involved at a technical level. Apart from that, frequently they would say no. But that's just reference for the country level. Quickly on the regional, I think there are definitely benefits of a regional approach given the nature of regional crisis. I think obviously it's also good to talk with UNHCR about that, given that many of the refugee crises that we currently have are regional in dimension. I haven't seen myself personally MHPSS specifically coordinate regional coordination mechanism. We have seen child protection to some benefit, but I would actually also ask Sarah and Fahmy to come back in on that if we could note the question and get some examples.
Marcio, is Sarah or Fahmy answering?
Yes, please go ahead, Rabih El Chammay. Thank you very much, Michael.
So when it comes to regional coordination, we don't have anything in the region to my knowledge. So I don't have much to say around it. When it comes to donors, on the other hand, we've noticed the importance of having a direct discussions with donors. We started with bilateral discussions, and lately we've been inviting them to the same table in the ministry to discuss together who's covering what, why, within which funding mechanisms, and ensuring that their action plans are agreed upon by the line ministries, whether it's the Ministry of Public Health or the Ministry of Social Affairs. So the program is seated in the Ministry of Health, but we work very closely with MOSA, and we are in a way the technical backup for the Ministry of Social Affairs in Lebanon when it comes to MHPSS. So their activity related to their area also within their action plan, for example, with big entities such as UNICEF or big donors, usually is part of our discussion as well. And it's important to say that when this relationship between donors and government is well articulated, even if the funds are flowing to INGOs or local NGOs, would increase accountability specifically towards the population. Because as we all know, in terms of funding, there is some perversion in a way that might happen, in which NGOs might be more, or might feel more accountable to their donors than to the population they're serving. And we've all seen, I'm sure, examples of that. So having everyone around the same table again, talking and ensuring accountability of every action taken and how it will contribute to building a system and not building vertical activities is key.
Thank you so much, Rabih. We're finishing the webinar. It has been such an informative webinar, and I know, just to say that we had more than, I just checked now, 220 persons that registered for this webinar, and around 80 persons that's participating in this webinar here. We're going to post it online, and we know that in a few days it's going to be hundreds of views. It has been, I can tell you, one of our webinars with most participation in our history. And I think the reason is actually people in the field, they indeed are challenged by so many questions when it comes to coordination mechanisms. And indeed, as a person myself that came from the field, I always was also stuck or shocked with this question of if humanitarian mechanisms are there, and organizations and agencies and persons, they are there with the aim to help the population and to serve the population, why there is so much problems in coordination and why it's so much competition, no, in the field. And I think this is an ongoing question which doesn't have a simple answer, and I'm so glad to hear here today so many indications, points, and good examples that are very inspiring. So thank you very much. We might come back to the two of you to future webinars. We very much appreciate it. And to the participants today, thank you so much for your patience. Today we had some technical issues, I know. And it extended a bit more than we expected. We appreciate your patience. And in about a month's time, keep checking MHPSS.net website. We should have another webinar in around 1 month. We have 2 webinars already in the pipeline. I'll keep a secret now to the topics, so keep checking that. And thank you so much, everyone. And we are finishing the webinar.
Thank you, Marcio. Thank you. To Michael for also being part of this, and Fahmy. And thank you for giving us the chance to share our learned experience. I know it's not easy for anyone who's working within the humanitarian settings. So please feel free also to reach out if you have any questions or would like to continue any discussion. And thank you again, Marcio, Ananda.
Renata is always around. She's our secret behind the scenes that is helping always the webinars. And without her, the webinars would be impossible.